Thank you, everyone, for joining today's meeting provided by the GAP MASLD MASH Community Network. My name is Allison Moser, and I'm a hepatology nurse practitioner at Rush University Medical Center in Chicago, Illinois. And today we're going to be talking about MASLD pharmacotherapy. Please make sure you scan this QR code in order to record your attendance for today's meeting. I'll leave it up there for a few seconds. As of last year, there were no approved treatments for MASLD or MASH. However, both vitamin E and pioglitazone could be considered as off-label treatment options. Last year in March, Resmetirom was the first and only FDA-approved treatment for MASH in patients with stage 2 to 3 fibrosis. Prior to the approval of any medications, and now meant to be used in conjunction with, is the underlying treatment and arguably the most important treatment, including good control of metabolic comorbidities in order to reduce cardiovascular disease risk, as well as controlling obesity. And we know that patients who don't have advanced fibrosis or those without F2 fibrosis or higher are at higher risk for cardiovascular disease and cardiovascular related events, making it really important that they're having good stringent control of their blood sugar, their blood pressure, and their cholesterol. An important caveat is that statins are considered safe in patients with chronic liver disease, even among patients with compensated cirrhosis, and they can be considered in patients with decompensated cirrhosis as well. MASLD does not increase the risk of drug-induced liver injury with statins. In order to control obesity, we recommend lifestyle modifications, including diet as well as physical activity, with the ultimate goal of weight loss. And we target 7 to 10% because we know that that amount leads to MASH resolution as well as fibrosis regression or improvement. In terms of diet, we recommend the Mediterranean diet since that's been the most studied and shown to be the most effective. Additionally, it's supported by all our major society guidelines, including those for obesity medicine, endocrinology, as well as for hepatology. For physical activity, we target over 150 minutes of moderate intensity or more than 75 minutes of high intensity exercise per week. However, we know that the number of those that are able to successfully achieve weight loss through lifestyle modifications alone is quite low. Even lower, the number of those who are able to sustain that weight loss. So we can use other tools as well, like weight loss medications, including GLP-1s and coagonists, and endobariatrics, as well as bariatric surgery. Although bariatric surgery is considered quite invasive, it can and has shown to lead to MASH resolution, as well as improvement of fibrosis, and additionally controls many other components of the metabolic syndrome. However, that being said, patients with cirrhosis are at increased risk from a surgical standpoint. So while it can be carefully considered in somebody who has compensated cirrhosis, it should be avoided in somebody who has decompensated cirrhosis. So let's now talk about GLP-1 receptor agonists and how they work. After we eat, our body releases a hormone called GLP-1 or glucagon-like peptide 1, and that plays a key role in regulating blood sugar as well as appetite. First, GLP-1 stimulates insulin secretion, but only when glucose levels are high. This is important because it helps lower blood sugar after meals without causing hypoglycemia. At the same time, it also suppresses glucagon, the hormone that usually raises blood sugar. So this dual action helps keep glucose levels in check. GLP-1 also delays gastric emptying, meaning that the food stays in the stomach longer. This slows down how quickly glucose enters the bloodstream, helping to avoid those sharp post-meal spikes as well as prolong satiety. And finally, GLP-1 has a direct effect on the brain, specifically the hypothalamus, where it promotes feelings of fullness or satiety, leading to a natural reduction in caloric intake. Now, GLP-1 receptor agonists, or GLP-1s, are medications that mimic this natural hormone. They bind to the same receptors and trigger the same effects. So in clinical practice, these drugs help lower blood glucose. They also support weight loss, making them a powerful option for managing type 2 diabetes obesity, as well as most recently, MASH. Just a few weeks ago, semaglutide was FDA approved for the treatment of MASH in patients with stage 2 to 3 fibrosis. And this is based on the Essence trial, in which semaglutide 2.4 milligrams once weekly led to significant MASH resolution as well as fibrosis regression or improvement. In terms of MASH resolution, this occurred in 63% of patients who were on semaglutide, compared to only 34% of patients with placebo. And 37% of patients on semaglutide had fibrosis improvement, compared to only 22% with placebo. Something important to note is that many of you may be GI or hepatology providers, that GLP-1s do delay gastric emptying, so they do have an increased risk of aspiration with anesthesia. Typically, we hold them 7 days before any scheduled GI procedure, so upper endoscopies or colonoscopies, but this may be institution specific. The use of vitamin E is controversial, and it actually differs between our American and European society guidelines. Vitamin E acts as an antioxidant that reduces oxidative stress and liver cell damage. So it helps protect liver cells by neutralizing free radicals, lowering inflammation, and improving liver enzyme levels. The PIVENS trial was a landmark study that showed vitamin E at a dose of 800 international units per day significantly improved liver histology, particularly steatosis, inflammation, and ballooning, which all are associated with MASH among non-diabetic patients. However, it did not improve fibrosis, and its benefit in diabetic or hypertensive patients remain unclear. Additionally, there are some concerns about some potential long-term side effects, like bleeding, specifically hemorrhagic stroke, as well as a possible association with prostate cancer. Just recently, a global MASLD and MASH consensus guideline was published in Gastroenterology, and this was from world-leading experts in MASH, and they do advise against the use of vitamin E as a treatment for MASH, given the risks outweigh the benefits. Pioglitazone was also studied in the PIVENS trial at a dose of 30 to 45 milligrams per day in patients with MASH and type 2 diabetes, and it showed no benefit over placebo for the primary outcome of improvement in histological features of MASH. However, it did show some significant benefits in secondary outcomes with improvement in cardiovascular risk. It does have a well-established side effect of weight gain, which is counterproductive in this patient population, fluid overload, bone fractures, as well as a possible association with an increased risk of bladder cancer. In March of last year, Resmetirom was the first and only FDA-approved treatment to be used in conjunction with diet and exercise for adults with non-cirrhotic MASH with that stage F2 to F3 fibrosis. And it's a thyroid hormone receptor beta agonist, so it selectively binds to and activates thyroid hormone beta receptor in the liver. Thyroid hormones are produced through the hypothalamic pituitary thyroid axis, with the thyroid stimulating hormone playing a pivotal role. These hormones regulate various metabolic activities across multiple systems, including the liver. The thyroid hormone receptor exists in two major isoforms, thyroid hormone receptor alpha and thyroid hormone receptor beta. Thyroid hormone receptor beta is predominantly expressed in the liver, making it a crucial target for liver-specific metabolic regulation. Resmetirom is an oral medication that selectively activates thyroid hormone receptor beta in the liver, and by mimicking the action of thyroid hormones, it enhances liver-specific metabolic processes without significant effects on other tissue. This selective activation is achieved through its high affinity for thyroid hormone receptor beta, leading to improved metabolic functions within the liver. In the context of MASH, it exerts several beneficial effects, including lipid metabolism enhancement. It enhances thyroid hormone receptor beta in hepatocytes, upregulating genes involved in fatty acid oxidation, as well as lipid metabolism, thereby reducing hepatic fat accumulation. It also increases the expression of bile acid synthesis enzymes, promoting the conversion of cholesterol to bile acids and enhancing cholesterol efflux from the liver. Additionally, it stimulates mitochondrial biogenesis and facilitates the removal of dysfunctional mitochondria, enhancing the liver's capability to metabolize free fatty acids. It also has anti-fibrotic action, so it reduces fibrosis by decreasing the activation of hepatic stellate cells, which are responsible for collagen deposition. So all of these mechanisms collectively contribute to the reduction of liver fat and inflammation that's associated with MASH. The FDA approved resmetirom under an accelerated approval pathway, which allows for earlier approval of drugs that are treating serious conditions and address an unmet need. And this was based on the Maestro-NASH trial, which is an ongoing phase 3 randomized control trial of resmetirom in biopsy-proven patients with MASH with fibrosis stages of F1B, which is a little worse than F1 and used in clinical trials, F2 or F3. And 966 patients were randomized 1 to 1 to receive once daily resmetirom, either 80 milligrams, 100 milligrams, or placebo. And the two primary endpoints that they looked at after 52 weeks were MASH resolution without worsening of fibrosis, and improvement in fibrosis by at least one stage without worsening of MASH. In terms of safety, the most common side effects are GI related, typically diarrhea and nausea, and these tend to occur over the first 4 weeks and then resolve with very low rates of discontinuation. Additionally, in the clinical trials, there was one patient who had a very high elevation in their liver tests, and although this was thought to be due to autoimmune hepatitis, it is recommended to check liver tests at 3, 6, and 12 months of treatment. It's also common to see patients will have elevation in their liver test at 4 weeks that resolves at week 8. So in my clinical practice, I do check at these intervals as well. Both the 80 and 100 milligram dose were superior to placebo in terms of MASH resolution and improvement in fibrosis by at least one stage. For MASH resolution, this occurred in 30% of patients on the 100 milligram dose, 26% of patients on the 80 milligram dose compared to only 10% in placebo. 26% in the 100 milligram arm had fibrosis improvement by at least one stage or more, 24% on the 80 milligram arm compared to 14% with placebo. So the ideal patients for treatment are adults with non-cirrhotic MASH with that stage 2 to 3 fibrosis, keeping it in mind that it's approved in conjunction with diet and exercise, so that counseling still needs to be going on with patients. There are some considerations for drug-to-drug interactions. Medications that should be avoided are strong C2C8 and or OAT-P1B1/3 inhibitors. These are all listed here. The majority of these are antiretrovirals as well as a few antibiotics. There are some medications that require resmetirom to be dose reduced, including clopidogrel, defersarazox, which is a chelation medication used in the setting of iron overload, and trimethoprim. So the 100 milligram dose gets reduced to 80. The 80 milligram dose gets reduced to 60. And there are some medications that are increased risk of exposure that you can see listed here. And certain statins do need to be dose reduced. So the daily max amount of pravastatin and atorvastatin is 40, and simvastatin and rosuvastatin is 20. There are some considerations in regards to duration of treatment as well as monitoring. Currently, there's an ongoing study looking at the long-term safety and efficacy of resmetirom over 54 months. Additionally, there's a study specifically looking at it in patients with cirrhosis. The early data is promising. We're seeing significant reductions in liver stiffness measurements as measured by VCTE, but we're still waiting on the full results to understand its role in more advanced disease. Likely, we're going to need to restage fibrosis as well as steatosis with non-invasive tests, such as VCTE or FibroScan, MRI with proton density fat fractionation. However, that being said, that's not widely available, a CAP or ELF. And then there are expert panels that are currently working on cut points as well as frequency for testing. I did mention to you that global MASLD MASH consensus guideline that was published in Gastroenterology. I would recommend giving that a read because it does address some of these issues. Now, there are still some important questions we need to keep in mind as we think about the future of resmetirom. First, widespread use is going to hinge on insurance coverage. As with many new therapies, access depends on whether payers are willing to cover the cost, which so far they have. Another major clinical consideration is the appropriate frequency of disease staging and lab monitoring to monitor patients who are on the medication. As we begin to use this therapy more routinely, we're going to need clear guidance on how often to assess fibrosis, lipid profiles, thyroid function, and liver enzymes. The American Association for the Study of Liver Disease, or ASLD, does provide practice guidelines, but keeping these updated and standardized is going to be crucial to avoid both under and over monitoring, which can lead to missed disease progression or unnecessary healthcare costs. Another unanswered question is the optimal duration of therapy with resmetirom. Should patients remain on treatment indefinitely, or is there a defined endpoint, such as regression of fibrosis or normalization of non-invasive markers? Additionally, we don't yet know when, if ever, it would be appropriate to stop treatment. So this does create a gray area for long-term care planning. But that being said, the ASLD, as well as this MASLD-MASH consensus guideline, does provide recommendations on these issues. There are multiple agents that are currently in clinical trials, which is quite exciting for our MASLD and MASH population. With semaglutide recently being approved, there's a lack of head-to-head studies comparing resmetirom to GLP-1s. These are both promising classes, but without direct comparisons, it's hard to say which might be preferred in this patient population. So thank you for your attention. Please make sure to visit the GAP MASLD MASH Community Network for additional disease state education, as well as a Resmetirom webcast. And I'll leave the QR code up here for you. At this time, I'm happy to answer any questions that you guys might have.